South Carolina. Can everybody hear me fine? Okay, great. I'm going to share a little bit about the South Carolina Maternal Mortality Review Committee, highlight some data and recommendations from the committee, and address discrimination and preventability in the context of pregnancy-related deaths. So these are some of my references and data sources, and the majority of data will be coming from the legislative brief and also 2 DHEC surveillance programs, the South Carolina Behavioral Risk Factors Surveillance System, or BRFSS, and the South Carolina Pregnancy Risk Assessment Monitoring System, or PRAMS. So in 2016, the South Carolina Maternal Mortality Review Committee became legislative mandated, and it directs DHEC to convene the committee. The committee uses the CDC model for best practices and consists of approximately 30 members, multidisciplinary and statewide. The pregnancy-associated deaths are identified primarily from the Office of Vital Statistics. Data is collected from data sources to include the review of medical and provider records, law enforcement records, coroner reports, autopsy, toxicology reports, pharmacy records, family interviews, as well as the death certificate and birth certificate. All the data is entered into a standardized database, and each death is reviewed using a standardized approach. Annually, a legislative brief is published, and it highlights the data and recommendations. So the scope of the Maternal Mortality Review Committee is to review all pregnancy-associated deaths of persons with an indication of pregnancy up to 365 days at the end of the pregnancy, regardless of the cause. And the mission is to identify contributing factors surrounding the deaths and make recommendations to prevent future deaths, with the vision of eliminating preventable maternal deaths. So these definitions are important to understand as they are the framework for the data analysis. If we think of pregnancy-associated deaths more as a global term that is used to encompass all the deaths that occur during pregnancy or within 1 year after the end of the pregnancy, regardless of the cause. And then when we break that out into pregnancy-related deaths, we look at that same time period. However, the pregnancy-related deaths occur because of a pregnancy complication or a chain of events initiated by the pregnancy or the aggravation of an unrelated condition by the physiologic effects of pregnancy. So an example of this would be like a hemorrhage due to a placenta accreta. Pregnancy-associated but not related deaths, again, the same time period. However, the pregnancy and the death are not linked together. In other words, it's coincidental that she died and she was pregnant. An example of this would be a motor vehicle accident. When we look at the figure of the tree on the right, only a small subset of the deaths reviewed are pregnancy-related. So combined in 2018 and 2019, 42 women died because of a pregnancy complication. However, the committee reviewed 115 pregnancy-associated deaths. So Maternal Mortality Review Committee's data is the gold standard when we look at the reporting of pregnancy-related mortality ratio. The pregnancy-related mortality ratio is the number of pregnancy-related deaths per 100,000 live births. So the national average was 17.6. However, in 2019, South Carolina saw an increase of 9.3%, which equates to 38.6 deaths per 100,000 live births. And when we look at the racial disparities, when we look at Black mothers experienced a 67% higher pregnancy-related mortality ratio than their white counterparts. And when we look at the top causes of death, we can see here, as far as cardiomyopathy, non-Hispanic Black women, that was the leading cause of death in 2018 and 2019, whereas mental health conditions, which also does include substance use disorder, was the leading cause of death for non-Hispanic white women. So this is actually the first page of the committee decision form that is used at meetings to decide if the death was pregnancy related. The committee makes determinations regarding special circumstances for each death, and the special circumstances are obesity, discrimination, mental health conditions, and substance use disorder. So when we look at the data for these special circumstances, we can see in 2018 and 2019 that over 50% of the pregnancy-related deaths, discrimination was a contributing factor. And when we look at substance use and mental health conditions, over 25% of each of those were a contributing factor, and obesity, almost a quarter of them. And we're going to talk about discrimination a little bit more in depth, so I'll save that. We'll save that part for a future slide. So I want to talk about each one of these individually. So we're going to talk about obesity. Excuse me. So in South Carolina, 38% of women of reproductive age reported that they were obese. But when we look at the racial disparities, non-Hispanic Black women, over 50% of women self-reported obesity. So this has implications regarding obesity is one of the contributing factors with maternal deaths. So as far as a recommendation, the South Carolina Maternal Mortality Review Committee was asked to prioritize the recommendations. And this was the number one recommendation that came out of the committee last year or this year, is all birthing women should have an established primary care provider who can address chronic conditions such as obesity, mental health conditions before, during, and after pregnancy. So, and like, how is this accomplished? This is accomplished through care coordination and referrals. When we look at mental health conditions, 29% of women of reproductive age reported having depression, and this was the highest among non-Hispanic white women of over 37%. Additionally, 24% of women reported that 14 or more days that their mental health was not well. And this was highest also in non-Hispanic white women. And when we look at substance use disorder, 10% of women reported ever having a problem with drug or alcohol. And this was most prevalent in non-Hispanic white women of 13%. And additionally, when we look at new moms, 5% reported prescription opioid use during pregnancy. So what is the recommendation and the clinical application? There are two actually that specifically address mental health conditions and substance use disorder. And that is, all birthing women should have a screening, brief intervention, referral, and treatment screenings for mental health, and be screened for substance use, domestic violence, chronic disease at the initial prenatal appointment, during pregnancy, and postpartum follow-up. So this is ongoing screenings and discussions about mental health conditions and substance use disorder should occur throughout the spectrum when the woman receives care for during the pregnancy and in the postpartum period. And again, we see the same recommendation about women having an established primary care provider. So then when we talk about discrimination, and 50% of the pregnancy-related deaths, this was identified as a contributing factor. What do we mean as far as discrimination? Discrimination is treating someone less or more favorably based on the group, class, or category they belong to, resulting from biases, prejudices, and stereotyping. It can be manifested as differences in care, clinical communication, and shared decision-making. So when discrimination is determined by the committee under this special circumstances, it encompasses race, discrimination based on race, ethnicity, weight, diagnoses of mental health conditions, and substance use disorder. This is all encompassed under this category in this special circumstance. When women in South Carolina were surveyed, this is reproductive women, age 18 to 44, 5% felt that they were treated worse than other races when seeking health care. However, this was more than doubled with non-Hispanic Black women at over 12%. So this comes from our BRFSS data at DHEC. So discrimination can be difficult to identify when reviewing medical records for pregnancy-related deaths. And what are some of the words or documentation in medical records that can be identified that could indicate discrimination? And these are some of them. Drug seeking, or maybe the word addict, non-compliant or refused. Negative documentation related to physical appearance, such as weight, tattoos or piercings, race or ethnicity, related to pay, source for care, or related to age. So I talked about the special circumstances of discrimination, and that is more of a global term. But how is racism identified within the context of pregnancy-related deaths? The Maternal Mortality Review Committee looks at two types of racism: interpersonal racism and structural racism. So I want to focus on both of those. So first, interpersonal racism. This occurs when discriminatory interaction occurs between individuals based on differential assumptions about the abilities, motives, and intentions of others, resulting in differential actions toward others on their race. It can be conscious or it could be unconscious. It includes acts of commission and acts of omission. It manifests itself as lack of respect, suspicion, devaluation, scapegoating, and dehumanization. So this occurs because of communication failures, stereotyping. It manifests itself in microaggressions and implicit biases. And then when we look at structural racism, this is more the systems of power and historical injustices and contemporary social factors that systematically disadvantage people of color and advantage white people through inequities in housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice. This is manifested in the lack of resources and policies, and it occurs more on the institutional level. So next, I want to break each one of these down and talk about some examples of interpersonal racism. One example is low expectation of patient engagement and failed decision-making. This is an example. Providers' notes show decisions were made without consultation or shared decision-making tools. And a family interview reports that the decedent was frustrated and felt that the provider was not listening. Ignored or improperly treated symptoms and pain and delays in treatment. An example is the decedent spends 14 hours in triage and does not receive the standard of care. Notes throughout the medical record indicate the provider did not take action based on the patient's acute condition and reported pain levels. An example of explicit biased interactions with service providers. This is an example. As an a patient was en route to the hospital during an emergency event, the family tries to flag down a police officer for help, but the officer's initial response was to order Black male family members to the ground while their hand is on a taser. And this is some examples of structural racism. It can be manifested by lack of providers accepting patients insured by Medicaid in a predominantly Black neighborhood. Just the decedent delay taking postpartum care due to transportation, unavailability of transportation, the availability or the lack of availability of translation services throughout perinatal and emergency care. The full medical history of the mother is not known because translation services were not available. So I apologize. This is very small, but this is a conceptual model of how racism operates and results in inequities that can result in maternal mortality. This slide is going to be available after in the slide deck, but if you look over at the column to the second to the right, I just want to read off a few of the manifestations in healthcare that can happen, some additional ones in interpersonal racism. That is concerns not being addressed, delays in treatment, victim blaming, improperly treated symptoms or ignored symptoms, improperly treated pain. And as far as structural racism, we talked about not having transportation, the lack of providers accepting Medicaid patients, inadequate healthcare coverage and duration, and lack of institutional policy on anti-racism. So this slide right here incorporates a lot, but this will be available in the slide deck for you after. So what are some recommendations about racism, and what did the committee, this is from the committee. The first recommendation does address interpersonal and structural racism. Recognize and address racism and improve quality of care to birthing women of color. This is done through implicit bias training for all staff and providers caring for pregnant and postpartum women. And birthing women of color should receive equitable and comprehensive care during pregnancy and the postpartum period. South Carolina did adopt last year the extension of Medicaid for 12 months postpartum, and that is a huge step in helping get equitable care for women. And all South Carolina hospitals and obstetric providers should utilize interpretive services to assist birthing women when English is not their primary language. So now I want to pivot over to talking a little bit about preventability. And in South Carolina, women who resided in a rural county had over a 70% higher pregnancy-related mortality ratio. And over 70% of pregnancy-related deaths occurred in the postpartum period. So 45% of women died within postpartum days 1 through 42. So historically, women would be getting a 6-week postpartum checkup. The committee recommends that all women get a postpartum appointment between 1 and 3 weeks. You know, having this touch point, the provider can address chronic conditions such as obesity and high blood pressure, could address mental health conditions, and a depression screening could be done. And this would also be a great time to suggest that she find a primary care provider and help link her up to getting a primary care provider. So when we talk about preventability and was the death preventable, this is a yes/no question. And if there was at least some chance to alter the outcome, then the death is deemed determined by the committee to be preventable. So prevention just doesn't occur at the provider level. Prevention occurs at the patient and family level, the provider level, the facility level, the system level, and the community level. And over 80% of the deaths in 2019 were determined by the committee to be preventable. And we look at additional contributing factors for pregnancy-related deaths. This is a list that the committee looks on and evaluates for each level. The contributing factors that are identified in red were the most noted in the 2018 and 2019 pregnancy-related deaths. And just some strategies for preventing pregnancy-related deaths is step one is to use the data to understand the scope of the problem. Step two is to understand the context of the solution. Step three is to identify potential goals and strategies. And step four is to act on the strategies. So what is being done in South Carolina to prevent maternal mortality? And this is not an all-encompassing list. It's just some of the things that are being done. South Carolina has a perinatal collaborative, which is the BOI, and it meets monthly to improve women and infant health care. South Carolina is an AIM state and focuses on safety bundles at the hospital level, currently focusing on hemorrhage. In April of 2022, South Carolina extended Medicaid coverage to 12 months postpartum. South Carolina also has their regionalizational care system to help infants and mothers get to tertiary care centers to get the care that they need. Educating providers and hospital staff. This is being done through a lot of hospital systems have mandatory implicit bias training, and also to educate providers and staff regarding how to respond in hospital emergencies. Partner with our stakeholders and collaborate with community partners to increase funding on for maternal health at the local, state, and federal level, and also to promote the CDC Hear Her campaign. If you aren't familiar with the CDC Hear Her campaign, I encourage you to Google that. It is a campaign that promotes education and advocacy for women. There is printable and downloadable information. There's a provider section as well as a patient section. And actually, just this morning, I got an email about they have some new handouts and refrigerator magnets available. One of the things that you might be familiar with, you could just go to the next slide, please, Rachel. This is one of their, the CDC Hear Her campaigns, one of their literature that you're probably most familiar with, which is the urgent maternal warning signs. And they just came out with refrigerator magnets that they you can request, and they'll send you for, if you want information about that, please feel free to email me. I can, I'll be happy to forward you that email that I got this morning from them. And thank you for your time today. The QR code, if you don't have a copy of the full 2023 legislative brief, that QR code can will get you that, and will give you all the information about additional data and all the recommendations that the committee had recommended for this past year.